Hello friends, welcome to today's lecture. So today we'll discuss something about severe dengue infection. You might call it dengue, whatever. I'll call it dengue. So please bear with me over here. So we'll begin with the severe dengue infection now with rains coming, and rains have come. So you need to be wary of this dangerous virus caused by Aedes mosquito. There are two Aedes albopictus and Aedes aegypti. So these two are the tiger mosquitoes that cause severe or the dengue infection. Now, when you go to the dengue, there are DEN. There are 4 types of dengue viruses: DEN 1, 2, 3, and 4. Some books mention also 5, but it has not been discovered for sure. So we'll take 1, 2, 3, 4. There are 4 variants of the virus, and it has a non-structural protein NS1. There is NS2A. There is 2B. There is 3. There is 4A. 4B and 5. So total there are 7 non-structural antigens present inside the dengue virus, and NS1 is the investigation of choice we use for dengue infection for the initial week of the dengue infection, usually up to 5 to 7 days of the initial infection of the dengue. The investigation of choice is detection of NS1 antigen, and then there is the detection of IgM antibodies. So non-structural antigens are the ones that we see in the initial phases of infection, and there are capsid protein, precursor protein, then there are envelope protein, and there are more 3 structural proteins. So non-structural proteins are 7, and there are 3 structural proteins. So these are the few MCQs that there are total 7. Structural proteins are total 3, and there are 4 types: DEN 1, 2, 3, 4. Now, why does severe dengue occur in some people and severe dengue does not occur? So usually it is hypothesized that when you have the dengue infection for the first time, it passes off as a simple viral infection. You have fever, but you do not have many complications. But what happens is, once you are infected by one variant of the dengue virus, like DEN1, if you are infected with DEN1, the next time you get infected with any other type of virus, example DEN2 or 3, what happens is your body overreacts to that infection, and that causes the shock-like signs and platelet dysfunction and the other abnormalities. So the manifestations in dengue infection is following the viremia, primary and secondary viremia, and which occurs due to dysregulated immune function of the body. So that is the cause of severe dengue infection, and not the virus itself, but the body's reaction to the virus. And it does not usually occur during the first infection of dengue, but the following infections of dengue, and the body hyperreacts to that things. So now we'll take a spectrum of dengue. So dengue is generally classified as dengue with probable dengue, dengue with warning signs, and severe dengue. So as you might have guessed, it goes from this to this to this. So initially you have probable, then it becomes warning, then it becomes severe. So probable dengue is that the person lives in a dengue endemic area residence or visit, with fever and 2 other out of the list that I'll put forth here. So nausea, vomiting, NV, no D, please remember over here. So nausea, vomiting, there is a rash. The rash of dengue is called as grains of white in a sea of red. So when there is a severe rash, the entire body is red, and there are some spots which are of the normal skin color which appear white. So there is rash. There are aches and pains, because as you know, the fever of dengue is called as back break fever, or bone break, or a saddleback fever, and break bone fever. So that is the fever that occurs, there is a severe bone pain in dengue. So there are aches and pains. This then tourniquet test positive. We'll discuss about tourniquet test positive. Then there is leukopenia. Commonly we see, thrombocytopenia, and that is, we usually use thrombocytopenia as a marker of severity of dengue, but the thing in the criteria is leukopenia and not thrombocytopenia. And if there is presence of any warning sign, any of the warning sign is present, any warning sign, A, B, C, D, F. So any of the warning signs, so any of two of these, A to F are present, you can consider that the patient has a probable dengue infection. Now, warning signs. So what are the warning signs? And when the warning signs occurs, the diagnosis you keep as of the patient as probable dengue with warning signs, and severe dengue. So what are the signs you have to look out? Which are the warning signs for dengue? So there is abdominal pain or tenderness. There is abdominal pain or tenderness. There is a compartment syndrome, which is a common complication of abdominal compartment syndrome is a common complication of dengue because there is a massive third space fluid loss inside there might be, severe pleural effusion, there might be peritoneal effusions, and these are of transudative nature. So this is there, or there is clinical fluid accumulation. There is ascites, there is pericarditis, there is pleural effusion. A huge pleural effusion might also be present in a patient. There might be mucosal bleeds due to platelet dysfunction. There might be lethargy or restlessness. Now in pediatrics, if there is a severe involvement, the child will not say, but the child will be lethargic, or child will be, not speaking much. Child will be, sleeping all the time. Now that might be mistaken as a fever, because whenever we are having any febrile condition, we might be lethargic. So it might overlap, and we might miss it sometimes. So that is the issue. There is liver enlargement, hepatomegaly more than 2 centimeter. So which is suggestive of severe hepatomegaly, which might occur due to, the right ventricular failure. Myocarditis is a very, very complicated, very, very common complication in dengue, and which might later lead on the backflow, and there is liver enlargement more than 2 centimeter, or there is increased HCT lab proven. With decreased platelet or thrombocytopenia. So these are the warning signs, and if these are present, you have to keep in mind that it might get converted into severe dengue at any point of time, and the patient might go into complications, and the patient might die as a result. So there is a severe plasma leakage, which historically is called as dengue shock syndrome or dengue shock syndrome, DSS. Dengue shock syndrome, or it might be a dengue hemorrhagic fever. There might be severe bleeding, dengue hemorrhagic fever. It is a spectrum of DHF. So it is a spectrum. There is dengue hemorrhagic fever. So there is the first thing in severe dengue is dengue shock syndrome. Then there is dengue hemorrhagic fever or severe dengue hemorrhagic fever. And the third point is a severe organ involvement. Now, with severe organ involvement, there might be liver involvement, CNS involvement, and heart involvement. Three things: CNS, liver, and heart. So in CNS involvement, there might be impaired consciousness. In the liver involvement, the AST and ALT might be through the roof, more than 1000. Other causes where ALT, AST are more than 1000, please comment down below. I have covered that in my previous lecture. What are the causes of ALT, AST rising more than 1000? So one of the causes is a severe dengue infection, and there is severe organ involvement. And the third thing is a myocarditis. Myocarditis is a very, very common and a known feature in the dengue infection that occurs in the pediatric patient, and it is devastating. You start the patient dobutamine and patient does not improve, and you still give more dobutamine, and dobutamine itself, when given in long term or when given with myocarditis, it itself might cause myocarditis, or it might exacerbate the myocarditis further. So that is one of the common thing that you might see over here. Yeah, so So these are the signs of, severe dengue. So probable dengue, warning, dengue with warning signs, and severe dengue. Now, what are the natural course of disease? So natural course of disease. So the first phase is febrile phase. Febrile phase. There is high grade fever, saddle back, high grade fever with the probable dengue clinical features of nausea, vomiting, headache, retroorbital pain. There is generalized body ache, facial flushing. There is formation of rash. There is abdominal pain. There might be pharyngeal injection. There might be progressive fall in WBC and platelet count. And there are other signs. Now, in this phase, there is tourniquet test positivity. Tourniquet test positivity. So what is tourniquet test? Now, in tourniquet test, what you do is you take a pressure that is midway between systolic and diastolic pressure. You take it to that pressure and you keep it for 5 minutes and then release it. So it is also known as Hess test. The tourniquet test is also known as the Hess test. The Hess test. And you take a pressure midway between systolic and diastolic blood pressure. You keep it for 5 minutes and release it. If there are more than or equal to 10 petechiae per square inch, not square centimeter, per square inch, then you say that the tourniquet test is positive. And in this phase, usually you have to do NS1 antigen. The IgM is still not positive, and then there is the second critical phase. This is the afebrile phase. So the fever has subsided and you think that the child is out of danger, but it is this afebrile test where there is afebrile phase where there is critical things happening, and there is third space fluid loss. Third space fluid loss. There is ascites, there is pleural effusion, there is pericardial effusion. And what happens is the patient goes in shock due to this. There is third space fluid loss and the patient goes into shock. So what happens? What are the signs of shock? There is narrow pulse pressure, less than 20 millimeter of mercury. There are cold, clammy peripheries. There is acidosis. There is increased hematocrit, severe fall in platelets, there is severe fall in WBC count, and there is disseminated intravascular coagulation. There might be DIC. There might be progressive organ failure. Like we saw the 3 organs that are commonly involved. So there might be progressive organ failure. Hepatitis, encephalitis, myocarditis. So, this all occurs. So this is the critical or the afebrile phase where we need to, be very, very careful. And then there is convalescence phase, which usually occurs after 24 to 48 hours of the critical phase. And there is a resorption of the third space, the fluid that has accumulated in the third space, the peritoneal fluid and the pleural fluid and the pericardial fluid gets absorbed. And once this gets absorbing, the patient feels better, the patient has the energy, the breathlessness decreases, and the things happen. Now, severe dengue infection we have seen, and there are the severe dengue we saw, dengue hemorrhagic fever, there is dengue shock syndrome, and there is organ involvement. Now, there is a new term called as expanded dengue syndrome, where we have other organs involved. That are less common than the main 3: hepatitis, encephalitis, myocarditis. But here in expanded dengue syndrome, there is AKI, there is HUS, there is acute tubular necrosis. So here we see kidney involvement. Then there is myocarditis, pericarditis, pericarditis. There is CVS involvement. Then there is respiratory involvement. What happens in respiratory involvement? There is ARDS, there is pulmonary hemorrhage and edema and effusion. So that is RS involvement. Then in CNS we have encephalitis, encephalopathy or encephalitis. there are seizures, there might be febrile or due to the encephalitis or encephalopathy, and there might be intracranial bleeds. So that is what is involved in CNS. Then we see hepatic failure, cholecystitis, or cholangitis, and even pancreatitis. So that is GI involvement. There might be also melena present due to bleeding inside the GI, that is covert bleeding, and that might be diagnosed or occult blood test or OBT as we commonly call it. In eye, there might be conjunctival hemorrhage or macular hemorrhage, so which might lead to loss of vision. Now, another thing that happens in blood is HLH, hemophagocytis lymphohistiocytosis. HLH that I have covered in my previous lecture. So that might occur after the dengue infection or along with the dengue infection, and there is rhabdomyolysis. Rhabdomyolysis. So muscle involvement, or there might be myositis, viral myositis. So that is muscle involvement. So this is the expanded dengue syndrome, that these are the organ systems that are involved with dengue. The common three we know. These are the other systems that might be, diagnosed. Now for the diagnosis, less than 5 to 7 days, we do NS1 antigen. More than 7 to 14 days, we do IgM antibody. Now, there is some controversy regarding IgG titers. So IgG signifies older infection. Now there is no, any role of IgG, but when the IgG is extremely high, so the titers are, when you see that 1:2080 or 1280. So when there are titers more than or equal to this, there is very high high chances that it is a very severe dengue infection. So, IgG might be, used as a surrogate marker for the severity of the dengue infection, but obviously it is, evident critically and clinically, sorry. So it is evident clinically. So that is how, we diagnose, and the role of IgG is limited. Now, again, I'm sorry, there might be rapid test. There you can do PCR testing, or you might do ELISA testing. Now, what is the management? So management, the drug of choice, is fluid. You stabilize the patient with, and the fluid of choice is normal saline. So first we will go with compensated shock. The shock is compensated. So what we do is we give isotonic fluid. Our fluid of choice is NS. So you give isotonic fluid, that is crystalline fluid, 10 to 20 ml per kg for 1 hour. That is what you do. Till then you send the investigations, you get the baseline hematocrit, you do blood count, you do cross matching, you keep the blood ready, you do the coagulation profile, you cover the main three, you do the bilirubin, you do ALT, ST, you take a echo if it is possible, you do chest X-ray, USG abdomen to see the third space fluid, and you might send blood CS if you are suspecting, there might be any bacterial infection associated. So that is what you do in the first hour, and if there is, then you see for improvement. Now, again, there are two situations, that if improvement is present and improvement is absent. So now, if improvement is present, what you do is you give 10 ml per kg per hour for 1 to 2 hours. Then you give 7, then you give 5, then you give 3. Again for 2 hours. 2 hours you do this. And once the child stabilizes, you give fluid boluses as and when required for 48 hours. As required for 48 hours. And you can stop the IV fluids at 48 hours if the child is fine. So you can stop the IV fluid at 48 hours if the child is Fine. Now, if there is no improvement, then what do we do? So we check the hematocrit. We check the hematocrit after the, we have taken a baseline hematocrit. Now we take the another hematocrit over here. So then we compare it to the baseline hematocrit that we took before. So either the hematocrit has risen or normal. So it is the same, or it has risen, or hematocrit has decreased. So here are the two conditions, that hematocrit is the same, or it has increased, or hematocrit has decreased. So if the hematocrit has increased, you give another bolus of 10 to 20 ml per kg for 1 hour, and then you see for improvement. Okay. And if the hematocrit has decreased, then you have to suspect a overt bleed. There is bleeding somewhere because the shock is not stabilizing. Still the hematocrit is falling. So the blood has to go somewhere. So you have to suspect a overt bleed. So you give blood transfusion. And if there is no overt bleed, so if the overt bleed is present, give blood transfusion. If overt bleed is not present, then you give colloids. At this point, you have to give colloid 10 to 20 ml per kg per hour at this point, or else the colloids are not routinely advised in dengue infection. Now we go back again here that the hematocrit has risen. We give 10 to 20 ml per kg bolus for 1 hour, and we check for improvement. Now if there is no improvement, we again check the hematocrit and repeat this cycle again. There is no improvement, we check for hematocrit again. If the hematocrit has increased, we give more fluid. If the hematocrit has decreased, we have to suspect overt bleed. And if there is overt bleed, we give BT. If there is no overt bleed, then we have to give colloids. Now, if the improvement is present, yes, the improvement is present, then you have to reduce IV fluid to 7 ml per kg per hour. And again, we have to, go towards this. Have to go to this. So that is the management for, the compensated shock of the dengue. Again, for the uncompensated, the treatment is mota same. I'll post both the photos inside the Telegram group. But again, grossly, if you see, the treatment of both compensated and uncompensated is the same. And this is the guidelines of 2009 dengue guidelines, which was published by WHO in Geneva, Switzerland. And with this, the majority of the children recover without any issues. So this is the management of dengue. Now, monitoring of dengue is usually, you have to, ideally it is recommended that you have to see the hematocrit, 6 to 12 hourly, like either QID or BD, like twice a day. You have to check hematocrit 6 to 12 hourly. You have to check the urine output 1 to 2 hourly. This is all in critical phase. Okay, critical phase, you have to do this. You have to 6 to 12 hourly and 1 to 2 hourly urine output. Even vitals, initially you start with this, then you go to 2 to 4 hourly, and you have to check vitals every 1 to 2 hourly. So that is how you monitoring the you monitor the children. And if they go into the shock, and then you have to do a more frequent monitoring, like you have to take vitals every 15 minutes, or you have to do hematocrit every 2 hourly, or even sometimes we have done a hematocrit every hourly. So that is how you have to monitor the child. Now there are many complications that what are the indications of blood transfusion. So indications of blood transfusion, we have seen over here that if there is a shock like condition and there is overt bleeding, then we give these patients blood transfusion. And FFP and platelets are not routinely indicated for the patients, because there is no role, because there is platelet dysfunction, there is abnormal synthesis. So if you give platelet, it will get destroyed like anything. But again, if there is a severe clinical bleeding, or there are many issues, or there is extremely prolonged PT-INR and there are issues, then you can give FFP to those patients. But routinely they are not recommended, and they are selected as case-to-case basis. If there is renal failure, hepatic failure, CNS complication, you have to treat them accordingly. And there is a common complication known as acute compartment syndrome that occurs due to, the third space fluid loss. So what happens is that the intra-abdominal pressure becomes more than 20 millimeter of mercury, with oliguria, metabolic acidosis, impaired cardiac function, abnormal perfusion, and all that. What happens is there is acute compartment syndrome, and there might be, end necrosis or end arthritis. There might be issues. One of the common cause of death in patients with dengue is ARDS, and we have seen hemolytic uremic syndrome secondary to, and HLH, even HLH along with the dengue infection. Now, ideally, you have the recommendations of IV fluids are up to 48 hours, but after 48 hours, you have to, ideally, if it is required, then only you give fluids. Now, there is a vaccine called as dengue. Now, what happened with dengue is that when dengue was given in a population where dengue is not endemic, it itself causes mortality and morbidity. So the use of dengue is very, very, very much restricted to only the endemic zones. It is absolutely contraindicated in non-endemic zones, because when it was seen that it increases mortality when given in non-endemic zones, again, India is endemic, so you have to make your choice. So that is the treatment. And again, if there are complications, you have to manage as in basis. So that's all for today, guys. I hope you like the video, and if you like this video, please give it a thumbs up and like, share, and subscribe. Thank you so much.